Today is Technical Tip Tuesday. I had a patient with an upper extremity deep venous thrombosis, and I'm going to share that with you. So the patient that I have to show, you can obviously see left upper extremity edema as well as discoloration. Note the edema from the upper arm all the way through the forearm. All the digits are involved as well. Wasn't a whole lot of collateral up by the clavicle because this was an acute presentation. The patient had been in the hospital for pneumonia. You can see the left jugular on the top view there. The jugular vein is somewhat distended, but not grossly so, and you can see the echoes within the lumen. On the bottom, you'll see the color flow in the common carotid artery, and you'll see the jugular as I went distal, and the jugular got bigger, more thrombus there. That was not compressible at all. On this image, to your left, you're going to see a big blue arrow. This is a longitudinal view of the internal jugular as well as the bifurcation of the common internal and external iliac. The external is cut off a little bit. The internal you can see down below. But I wanted to show you a representation of a vessel that's totally open. So you can see that there's a little bit of plaque in the common, distal common, proximal ICA, but the jugular, nice smooth walls, not all that much distended, versus the picture to your right. This is the patient that I just showed you. So this is the jugular as well as on the left side there, proximal common, and you can see that the jugular is distended, there's no color flow, as well as there's intraluminal echoes within that vessel. And here's where we get into the good stuff. So in an upper extremity, one of the hardest things to do is to scan the subclavian and proximal axillary, because as sonographers, when we're trying to rule out deep venous thrombosis, we often use compressive measures, coapting the vessel wall. But in this case, because of the clavicle, we're unable to do that. So you're going to really have to rely on your color Doppler as well as your pulse Doppler. So the image to the left is the left subclavian. You can see the shadowing from the clavicle, but you can see that the subclavian is, there's no flow in the vein. When I moved distally to the axillary, I started to pick up some flow. However, the flow is continuous, and that would be because we're listening distal to a complete obstruction. The best thing you can do, because you're so limited, is you're going to really use that pulsed wave as an indicator. Now, unless the patient has bilateral upper extremity deep venous thrombosis or obstructive disease, you're going to be able to get the contralateral side. So if you look at the contralateral side, you have normal pulsatile respiratory flow. That is normal in the upper extremity. Now, as you move distally, it becomes less pulsatile, but in that proximal part, the subclavian vein and the axillary vein, often you'll see that pulsatile signal. If you don't see it, that's when you get concerned about proximal obstruction or thrombus. So you can see on the left side we have a normal pulsatile flow on the of the screen. That's that image, and then the right side image is that patient's left axillary abnormal continuous flow or loss of phasicity. I had the wonderful opportunity of writing a chapter in a book with Dr. Joanne Lohr from Cincinnati, Ohio. We had worked together for many years previously in our careers, but I wanted to do a quick review and summary of that article that we wrote. Basically, about 10% of all episodes of deep venous thrombosis occur in the upper extremity. There's definitely an associated risk for primary upper extremity deep venous thrombosis, including thoracic outlet or anatomic anomalies or coagulation defects. 20% of the episodes are actually unexplained. We have no idea why people have them. The risk factors secondary to upper extremity deep venous thrombosis are listed here, just as a quick review for you. Also, the most devastating complication of upper extremity DVT is the potential for progression to pulmonary embolus. In the past, it was thought for this to be rare, a very rare complication. Recent data, however, suggests that it may be present in as many as 36% of the cases. So no longer think of that upper extremity deep venous thrombosis as a benign finding. Pulmonary embolus is found more often in catheter-related upper extremity DVT and is twice as likely to be seen in connection with secondary DVT. And final tip is that the diagnostic accuracy of an upper extremity duplex scan is very good, with a sensitivity of 78 to 100% and specificity of 82 to 100%. So if the patient presents with unilateral, especially upper extremity swelling with discoloration, first line of defense, venous duplex. Thanks and have a great day.